You are live.
Yep. Well, good morning, everyone. Thank you for taking time out of your busy schedule to be here today. Both the executive committee members and we have some special guests and the people that are following this meeting on the webinar. I really appreciate, again, you taking time out of your busy schedule. This is going to be a little bit of a different meeting than our other executive committee meetings on the Texas Child Mental Health Care Consortium. We're going to have one topic that we're going to work through today, and that is to gather our thoughts and kind of refine our thoughts related to an approach for the American Recovery Plan Act and opportunities to use those resources to improve mental health services here in the state of Texas. And so a couple of things before we get going, we need to take the roll call, but I'd also want to remind members to refrain from using the chat box and chatting to everybody, because if we do that, then I have to read it in order to be in compliance with the Open Meetings Act. We take compliance with the Open Meetings Act seriously, and so unless you want to hear me just start reading things, I would ask you to raise your hand and I will call upon you and make sure we have an orderly discussion as we move forward. So with that, Luann, why don't you go ahead and take the official roll and then we'll get started.
Okay, here we go. Lakey.
I'm here.
Goodman.
I'm here.
Williams.
Howdy.
Liberzon. Harper. Wakefield.
I'm here.
Mitchell.
Here.
Thompson.
Here.
Martin. Here. Puddawelts.
Here.
Farmer.
Here.
Bryant.
Luann, did we lose you?
I think she's either asleep or frozen, or it could be her Aldopa wore off. That happened in these meetings.
We lost Southern. Oh, no.
Or she's just trying to fake us out. I do that sometimes, freeze.
Yep.
And then log off and they'll never know.
You want me to continue, Dr. Lakey?
Yeah, why don't you continue, Nagla?
Sorry, my internet went down. Sorry about that. Okay. Let's try this again. Bryant. I'm going to turn off my video. Maybe that will help. Okay. Nichols.
Here.
Gaines.
Here.
Martinez.
Here.
Borges. Nemiroff. Strakowski.
Here.
Hahn. Robert. Wagner.
Here.
Vo.
Here.
Flores. Bobatrope.
Here.
Pliska. Blader.
Here.
Escamilla.
Here.
Patriarca.
Here.
Taminga. Ibrahim.
Here.
Silverman. Keller.
Here.
Castle.
Here.
Wesley.
Here.
Okay, that's it. We're ready to go.
That's good. I'm here.
Okay.
Luann, can I introduce Dr. Tara Mitchell, who's joined us in trade spots with Dr. Nancy Trevino?
Yes, go ahead. Go ahead, Sarah.
Dr. Tara Mitchell, she's a child psychologist who joined us about a year and a half ago to help consult on and provide treatment on our consortium projects and really growing our program out here for therapy services and psychological training for our prac students and things like that. So I can't see her now. She left my screen. But Tara, can you say hello?
Hello. Hi, everybody. Glad to be here with you today.
All right, well, welcome. Good to have you here. And I think there are a couple of people that signed in the midst of that. We want to make sure the record reflects. Dr. Martinez is here. Octavia, good to see you. And anybody else? didn't hear their name called, if you'd like to.
Just confirming, I'm here, Steve Pliska.
Yeah. Good to see you, Steve.
I saw Jeff Newport and Roshni Coley. I saw them, I thought, flash by, but I don't see them now.
Yeah. Yeah, it's good. There's several other people that are here. I just need to make sure I have the official count of the executive committee members for the to make sure we have a quorum and follow the open meeting act. So with that, why don't we go ahead and get started? Michelle, let me bring you in before we jump into this. You sent me a message a little while ago, just wanting to remind folks of their PIAs and getting them back to us. Anything you want to say about that before we start?
No, just at this point, everybody should have their draft PIAs, and hopefully you're circulating those with your legal teams for review. Need you to get those. If you're happy with everything that's in there, get them signed, get them back to me, and then I will route them for signature on our side. So I think I've got UTMB so far fully executed, but all the rest are outstanding.
Yeah, if you could get those to us, that'd be great. We want to make sure we get the money out to you and make sure with the resources.
Michelle, can you forward that fully executed back to us when you get a chance?
Yes, of course.
Thank you.
It's a question. Are you talking about these new programs or something else?
Those were for the last biennium decisions from the legislature, the 118.5, and
Oh, those okay.
Those dollars go out.
I see. Okay. Thanks.
Okay. All right. So I'm going to jump in to the discussion today, and why don't we go ahead and put up the PowerPoint slides. Again, I would ask for a little grace, as we go through this today. This has been a very rapid process, and the slides just got to you because I was working on them just a little bit ago, trying to take all the information that you guys have provided us and put it into an understandable plan that we will be able to communicate with the legislature and hopefully have some opportunities to do some important things here in the state of Texas. So if we could pull up those slides, I'll go ahead and get started. You should have several things that we sent out to you last night. You have the summary document that we put together. We put together a little summary, and then all the additional proposals that were submitted. There's an Excel spreadsheet that shows the numbers, and we'll go work through those today. The challenge, I think, in the meeting today is we received 28 proposals. Again, a lot of them are very similar, and we've tried to bundle those into ideas. So we can't have a long discussion of each of the submittals and get through in our 2 hours. But I think we can hit the key key items and make sure that we understand the process, because this is going to be a process of getting there. Alan, let me go to you, and then again, if the folks can get the slides up, I'll go ahead and start working through them. Alan?
As we worked on ours, we had a couple of major pivots. So we didn't get ours in a timely fashion. So we're just about done, but the pivots are made.
Yep. Okay.
And David, I don't know if you saw my email this morning, but we got off the.
Yep.
We weren't aware of these, so there are things we would like to participate in. So maybe I could work with you on how to do that. Okay.
So quick check with my team. Are we having trouble sharing the screen, or I have it and I can start sharing it from here?
Can host enable sharing?
Yeah, could the host enable the sharing of the screen? Well, I'm going to start off.
It's ready.
Okay, if we could do that, that would be helpful. All right. So everyone should see the slides now in front of you. And so I've tried to organize these 28 items into certain buckets. And so what I'm going to talk about first is kind of the process. And I think that'll address some of the issues that we've already heard about and some other concerns that I've seen through email traffic today. And then we're going to walk through the kind of high buckets of kind of, as we try to categorize these and frame these items, kind of where we're currently in that process. So it's a little bit about the process. We asked each of our health-related institutions to provide us ideas for potential funding projects. And I think that's why this consortium was put in place. The legislature wanted to hear from health-related institutions that you are the experts in your communities, you're the expert related to your institutional needs and capabilities. And I'm always amazed by the expertise that we have around this virtual table. And the evidence-based practices and what would work in the state of Texas based on these ideas and in your community. And that's why I think it's very appropriate for the consortium to be a part of this process. So we asked you to submit those items, and I understand several of you still have items you want to submit to us. And this is a process, that's okay, but we're gonna need to get those in pretty quick. Our team worked over the weekend to try to organize these items. We worked yesterday trying to organize these items into some general themes, just so again, it doesn't look like a shotgun, but is a really targeted approach. And the reason I say that is that there were several ideas that were very similar, and so we've consolidated those into these themes. Today, we're going to review the items and those themes, but I'm not having a formal approval today. We're not going to vote this out because there's still work to be done in order to finalize our position and what we want to present to the legislature. So each institution, as we share these ideas, my goal is that you'll say, yeah, I want to be part of that one. Maybe I can't be part of this idea, but here's some things that now that's been put on the table that we could also do in this area. And we're going to try to build that then into the overall plan that we will provide to the legislature. I'm going to need to get that information though pretty quick. And so we're going to share this information, shared some of it last night, share this information with you today, but we'll need to have that information sent to us by the end of this week. So then we can massage it and form it into something that we can present to some key legislative staff in the next several weeks. There will be time to modify things. There's an ongoing conversation during a legislative session. And so we will need your continued input. But this is starting to quicken. That everything's been a little bit slow here because of the current special sessions, the issues that they've had with quorum. But now things are picking up, and we want to be ready before this next special session starts, that we can start those communications and the groundwork that we'll need to be accomplished for us to be successful. So we have categorized the current requests into these 5 buckets of work. And I'm going to go through in the next slides and kind of describe what these buckets of work include. And again, you have the details in what we sent out to everybody last night. The first bucket of work that we heard from you was that there's opportunities to enhance and to expand our activities related to CPAN. Whether it's through, and we'll walk through this in the next slides, Project Echo, a variety of other things that could be very useful in expanding CPAN services, but there's opportunities there. And so that's our first bucket of work. We also had several submittals related to our current work with the Texas mental health workforce and expansion of that workforce. And again, we'll walk through that in a little bit. TChat, there are opportunities to expand into different geographical areas. There's also opportunities to enhance the type of TChat services that were provided. And so we're going to, again, talk about those things together. It seemed to me that there was a group of projects that were focused on adults, but strategic areas of adult mental health services that need to be enhanced here in the state of Texas. And kind of talk about that a little bit now, and we'll talk in more detail. But one of those we've already had the discussion is in perinatal mental health, which really seems to be very closely linked to our current work. And we've already started those conversations related to opportunities here in the state of Texas. And then the fifth bucket of work that I've kind of pulled together, it's labeled research, but some of them aren't really research, that they're really looking at real-time data to improve the delivery of mental health services in the state of Texas that have a research component to them that are really important because of COVID and important because of other ongoing issues that our folks know are challenges here in the state of Texas. So when we pull together that total budget, and this is for 5 years, from 2022 to 2027, the current request is right at $225 million. Now, it's my full expectation that number is going to go up. We will continue to build upon that based on these themes. And then we will let the legislature decide on what they can fund and what they can't fund based on this framework. And then there'll be ongoing work that we'll need to do based on where they can land, and they have many other needs that they have to address. And so we just need to make sure we manage our expectations, but we also want to put those opportunities in front of the legislature so that if there's the opportunity that we can get these items funded. So why don't, in the next several slides, I'm going to go through each of these categories and at a high level talk about the ideas that we heard, and want to give you the opportunity to expand upon those. But again, I'm going to have to be pretty strict on time limits because I need to march through all of these items in order for us to get through the discussion today. So the first category of work has to do to enhancements and expansions of CPAN. And there's really kind of 4 items here when I pull it together and bundle it that I see related to opportunities to improve CPAN. One, several institutions, and I'll go back in a second to the institutions, they noted that there's some evidence-based suicide prevention programs for youth that would be very important to implement to prevent suicide. There's a group of projects to expand through technology the hours in which CPAN services will be available to primary care providers. There are some projects related to the implementation of pediatric collaborative care models through Texas. And then a final component that would allow children identified through CPAN that needed an in-person visit to obtain one. This has been a challenge that we've heard from many institutions, that you're consulting with a primary care provider and becomes clear to you that it really be beneficial for you to lay eyes on that individual and have a mechanisms to bring that individual in and talk to that individual so you can refine that treatment plan. So I want to start at the top of this list. And again, this needs to be very short, but I call out a couple of folks that had sent items in. On that first part, implementation of evidence-based suicide prevention programs. Dr. Williams, you and Dr. Trivedi had put some thought into this. You want to share some of those ideas that you had?
Dr. Trivedi on?
Yes, I'm on, Laurel.
Why don't you go ahead and take it away?
So this is, there is a evidence-based program, family-based, we call FISP, that's been shown to work for suicide prevention. And so the program is basically designed to train primary care providers in CPAN as well as in the Depression Research Network and Trauma Network to be trained to deliver this brief suicide prevention intervention when confronted with a kid who is expressing suicidal ideation or behavior. The idea is that at the end of the effort, primary care providers in a large array of systems will be well trained to deliver this evidence-based program. if they are well trained and they deliver, that is also in fact reimbursable so that it has a sustaining value for the state of Texas. So that the idea would be that at the end of this effort, Texas kids will always be able to get evidence-based suicide prevention program if they report suicidal ideation behavior to their primary pediatric practice or family practice, as well as obviously in psychiatry.
Okay. Thank you, Dr. Trivedi. Dr. Williams, anything else you want to add to that?
No, I think that, again, the model is hopefully very innovative and is going to partner with CPEN, because again, we will use the CPEN structure with all the hubs. Each of the hubs would have people become trained in this evidence-based program so that we can continue to roll it out over the years. So it's really a training model that has that hub approach to really make sure that we can expand out across the community.
Okay, very good. The other item that was in suicide prevention that was submitted came from UT Health Science Center Houston. Dr. Chin, I don't think she is here, but Dr. Babatop, anything you want to say about that?
Yes, Dr. Chen is one of our new recruits, child and adolescent psychiatrists, and she came up with this idea to implement the zero suicide framework within our pediatrician offices to promote better standards of care around suicide ideation. So what we plan to do is to teach the providers how to identify, screen for suicidal ideations, discuss risk factors, and to develop safety plans. We hope to expand on this approach by actually expanding to a live virtual consultation as well, to be able to guide them, support them with some of this education, medication, and treatment options. So basically, we are following the toolkit of to lead, train, identify, engage, and to transition and improve their practice guidelines.
So in that proposal, and again, you can look through it, the executive committee members, that there is a Project Echo type model that is also, that's part of that. So we have those items related to suicide prevention. That the next item that I've kind of put in here, during the process we did a month ago when we were looking at reallocation of funds, there was I thought a really good project at Dell Medical School that we weren't able to put funding in, but this is to use technology to expand the hours in which CPAN services can be available to primary care providers. And Dr. Coley or Dr. Strakowski, you want to kind of give that 30-second summary of what the idea here is?
Yeah, Roshni, can you do that?
I'd be happy to. So one of the feedbacks that we received from primary care physicians was that sometimes the hours of CPAN made it challenging in which to call and gain consultation. And so this was a large pediatric practice within our community, suggested that if we're on the same EMR, could we use direct messaging through the EMR itself or encrypted text messaging? So we use Tiger Text here at Dell Children's, and many of those providers are also on it. And so the idea here would be that we would do consultation, CPAN type of consultation based on best practices, all of the same things that CPAN embodies, but we would do it through direct messaging through the EMR or through encrypted text.
Okay, very good. The next component of this was the pediatric collaborative care models. Andy, I'm going to let you kind of start this conversation. You guys were very successful in getting a large grant you're going to be able to leverage in order to really do something meaningful here. You want to talk about that and the opportunity here through these funds?
Yeah, David, happy to. So we have a $10 million grant we got in partnership with UT Southwestern and the Dell Medical School. And the plan is over the next 5 years to pull in all of the medical schools except the ones in the Houston area, because Houston's like a state to itself. We just didn't have resources to go down there. And over a 5-year period to bring in and develop TA capacity to support the implementation of collaborative care and primary care practices that your schools are affiliated with. So we have technical assistance paid for in that, but what we don't have paid for are the startup costs that the hospitals have. So what we did was we put a proposal together where we would use these funds to pay for the hospitals to do startup costs. And we estimate about 40% of those hospitals health systems rather. So it's a health systems with primary care, but it's a whole health system. Could be FQHC network, doesn't have to just be a health system with a hospital, but we figure about 40% of them could be pediatric if we put a focus on the children's hospitals. We're already partnering with Children's Health in Dallas on a separate set of grants, but we don't have startup funds even in that grant for children's. And the startup funds average $100,000 to $200,000 depending on the size. So we thought $125,000 for each health system of startup costs, as well as $125,000 for each medical school who is willing to be part of this to be able to participate. We can do 20 health systems with that without any additional TA resources because we have them. If we want to go beyond that, and this would be for the Houston area, because we don't have any funds to do work with Baylor or UT Houston on this. So we put in 10 more that would bring in technical assistance funds where we would collaborate with the medical school and our team. So for $10 million total, we could work with 30 health systems, reach probably upwards of 10 million Texans in those footprints. I mean, Baylor alone, who we're working with, and Baylor's already happening, has 2 million folks, patients a year. So about 40% of this would be pediatric, 60% would be adults. So the 40% that's pediatric is in this part of the proposal. Danielle, and we're working with her team on this now. Danielle, for children's, it would provide, potentially startup to help you accelerate what you're doing. But I think, you're already doing this. I think the more important thing is it allows other health systems to say, hey, we've got our startup costs covered, and gives additional resources to each medical school to support your faculty that would collaborate with this. So I think of this whole $10 million, just under $1 million would come to us if we do the additional TA. But only if we do the additional. If we only get a portion of this, we would focus on the grants that just went to the medical schools and the health systems because we already have a large part of our work covered. So there you go, David.
All right, very good. And then Dr. Coley, you also had one. It's incorporated in everything else that everyone has, but it's a similar collaborative care model and maybe some opportunities for with what Andy's doing for us to kind of think, how we can all, how those things could align in moving forward. Okay. All right. And then the next item has to do with what I noted earlier, the need that our institutions are seeing that sometimes you need to bring somebody in. And the CPAN written model so far hasn't allowed that, and to ask for funds to allow those in-person visits. 2 institutions provided ideas, and let me back up just a little bit. I said this once, but I also want to repeat it again because I'm getting a couple of texts. This framework that we put out, this discussion today, there is opportunity that if your institution didn't put something in, that you're going to be able to. And again, the goal here is not to cut things out, but to provide these ideas so we can build upon them, whether the pediatric or the adult things that we'll talk about later. But we want to use this framework kind of moving those forward. And so again, just seeing several texts instead of me answering the text independently, just kind of want to say that again here in front of everybody. But Dr. Martin and then Dr. Coley, you want to talk a little bit about that need that you're seeing there and why we believe this is justified as a request?
Sure. Let's see. So the original reason that I thought of this program is when we were first setting up CPAN, we had consulted with Massachusetts, and this is the way that they do it. And they were very successful in getting pediatricians, other primary care providers on board. And supposedly they have like 99% of people signed up for the program. And as I've been doing CPAN more, and I'm the psychiatrist that's taking most of the calls, and also trying to get people to sign up. And one thing that seems to be keeping them from that is they really want to do the old-fashioned kind of referral that they did when they were a resident, where they had they went to a big school and they could just refer to child psychiatry, and they never had to think about that part again. So I think if we had a kind of a hybrid model where we do see the patient but just once, then they would feel more comfortable really giving CPAN a try. And there are some patients that are more complicated. So I think it would build trust on the side of the primary care provider. but then offer a lot in terms of the treatment of our sickest patients. And in our region, I think it would be highly utilized because we have 16 counties and the only county with a child psychiatrist is El Paso County. And so I think a lot of those rural areas would feel very comfortable having us actually see the patient and then implementing the treatment plan.
All right. Thanks, Dr. Martin. And Dr. Coley, anything you want to add to that? Sounds like it's the same need, right? You're seeing.
Same need. Yeah. When Dr. Martin mentioned it at the last executive committee, we started emailing back and forth because we are absolutely interested and see the same need. The one other thing that I would add, though, is that we looked at a model of 3 total appointments that could either be with a psychologist or a psychiatrist. One of the things that we've noted both in our CPAN calls and some of the TChat encounters is that there has been specific needs that could be helped with a psychologist, for instance, more developmental testing, being able to look at some more behavioral modifications that could be done in a very short-term brief model. And so we looked at a model that would be 3 total sessions. At the end of that, they would go back to the PCP. And we have some precedents by which almost all of our TChat medication management encounters, we collaborate and send back to the PCP. And so I think we just have to be careful in making sure that it doesn't take away from the utilization of the telephone consultation, because we want that to be primary. But so we're just coming up with the criteria in which how we would offer direct consultation.
Okay. Very good. So let's
just a quick question for Dr. Martin. I totally agree this would be a great thing, but just to clarify, we could do this by telepsych, right? Doesn't have to be physically in person. Yeah, great.
Yes, we could set it up as a hybrid model where the patients who are local could come in if they wanted, or we could do it even from the pediatrician's office. And I think that's how the Massachusetts did it. They do it from the pediatrician's office to the central CPAN hub.
Yeah,
Andy, I saw that you had a question.
Yeah, one thing I just want to emphasize in this, and I think this is important to keep in mind, the beauty of all of these proposals is they're really very one-time surge type things. I mean, the idea of even this is a transitional thing to get folks more engaged. There's ongoing funding that can support many of the children, Medicaid, other types of things. The trainings will be in place once they're in place. The collaborative care thing is totally one time, because once these practices are up and running, they'll be able to pay for these child consultations with Medicaid, because Medicaid now covers collaborative care. So that's just one thing that's super important for everybody to keep in mind. These are one-time things that will surge up to meet the demand that's present, but will also then, as it settles back down, there'll be ongoing other types of funding to cover it. So I just want to reassure folks that was kept in mind with all these proposals.
That's a good point. And as we finalize how we present that, so that's something that we're going to need to incorporate in the writing. And as I noted, I think on many of these, there's going to be other institutions that want to do the same thing. And so the goal today is to share those ideas. I think the in-person visit, there's probably multiple other ones that we'll want to, and we'll need to kind of bundle that then into kind of one conversation that we present to the legislature. But let me take about 5 minutes, and I know I'm going to be pushing hard through this meeting, but again, I want to make sure we get through in the 2 hours. Any other just general thoughts related to this approach for enhancement of CPAN before we move on to the next item?
David, we have one we've been working on. Just wanted to throw it out there. There are nurse practitioners that have specialization in mental health, working with children. And one of the things we were exploring was how to utilize those nurse practitioners at the state level. We have a training program at UTRGV that's virtual across the state. So that's one I would like to just suggest we consider.
Okay.
And we can work with the Massachusetts folks on how to integrate that.
If you send me a proposal and get it to me by the end of this week, we'll take a look at it and see how we can integrate that into what we have.
Thank you.
Let me go to Alan first, and then Laurel to you.
One of the things that we worked on with our CPAN folk is that we're finding that there's probably a need for psychoeducation in these primary care places. And so one of the proposals that is kind of making us really think about it is, can we provide some kind of group activity, not just individual activity, but group activity for families who really have questions or concerns about what is mental illness, what is the pathway, and the CPAN people can offer some of their social work activities with it. So it's a group activity. And I see that as a way that the PCPs would begin to then say, wait a minute, you know, here's something that I can get some folk into, families and students, to help them understand the trajectory or path of suicide or with depression or anxiety.
Okay. Again, Alan, if you put something on paper and send that to me by the end of the week, we'll figure out how do we incorporate that. Okay. Dr. Williams?
Yes, I think that all these ideas we've been talking about in various iterations, I think that Andy is exactly right. These are things that are surge for CPAN that we really would, I think, want to be moving into the future. And for the zero suicide, we've had conversations at the national level with their educational team, and they are super psyched with this idea that Texas could become a zero suicide. Texas already has a zero suicide initiative, by the way. But if we can get all 12 of our institutions to participate, to get the hospitals that we associate with to participate in, I just think this would be fantastic. So all of these ideas are very achievable with the current structure and with this sort of surge. So I think this makes me get more excited even again.
Very good. Dr. Wakefield?
Hi, and just listening to these proposals, Laurel, I was wondering if we included somewhere in here the echo for CPAN. I don't see it here really outside of the zero suicide framework, and also the continuing education CME that some of us are doing. That would be great to expand.
Well, I think that from the perspective, we're doing our first statewide echo
as well.
Our first statewide echo project just now. We didn't have additional funds, but if somebody wants to put in additional projects, I was just really, again, we have a lot of capacity within our teams to do a lot of education. So I wasn't thinking about adding from that perspective. I was thinking about a few things that we didn't really already have. So these ideas to me were really seemed like ones that we were looking at, but we weren't sure how to scale up to.
Okay. Very good. Why don't we go to the next slide? So the next group of projects have to do with the expansion of the Texas mental health workforce. So these will expand training opportunities, but the data that we've gotten so far is that are also of immediate benefit to improve the care in community health providers. Our CPWE program has been very well received, and there's opportunities to expand upon that. And so kind of three components here that are currently identified. And again, I think after the discussion, there'll be more that'll be identified. One, to expand, especially in West Texas and in East Texas, psychiatric resident rotations with community health providers. The second, and Sarah, I'm going to go to you to explain this, Sarah Martin, the opportunities with licensed professional counselor license and the need for some supervised training here. And then some additional fellowship slots for programs that are growing. Again, maybe this is an area that there may be some other institutions now that you have some additional, know where your current resources are and see some of the need we might be able to look at. But looking at the resident rotations, Dr. Wakefield, your proposal saw an opportunity in a large number of areas of West Texas that currently can't benefit from CPWE to be able to bring that service to them. Anything you want to say about that?
Yeah, I really modeled this over the East Texas Behavioral Health Network, Healthcare Network. And the idea is that there's a consortium of psychiatrists who are offering the service, telehealth services. I listed the website. I don't know if that's in the other materials for psychiatric services, psychological services, other counseling services via telehealth platforms to a wide network of local mental health authorities who are having more difficulty finding these expertise in their area. And I know that we have the same issue in West Texas, especially in our more rural local mental health authorities. So the idea was to create more of a West Texas behavioral health network, healthcare network, so that we could set standards of care and really do it for child psychiatry, because that seems to be even harder for people to find, and have those services across our entire region.
Okay. The next item, Sarah Martin, you want to, again, kind of that 30-second explanation of what this item is?
Yeah, so there's many people that go to UTEP and get their degree, but then they leave El Paso because they can't find a paid internship to do all of their hours for their LPC license. And counselors, so there's always been waiting lists for therapy, but it's just gotten worse during COVID. As everything's opening up, a lot of kids are having symptoms, and so the wait lists are just getting longer and longer for the counselors that do see kids. So it's for a while, it was up to like 10-week waiting lists for most of the big practices in town. So we just wanted to expand, especially now, and keep more people in El Paso and keep them from leaving to go to other places. And then also through CPAN, we've been working with a FQHC and that covers Alpine, Marfa, and Presidio. And they just got a grant for something similar, and they wanted to collaborate. So we could collaborate on the educational side of it and the structural side of it with them too. And that's a HRSA grant.
Okay, very good. And then Dr. Wakefield, back up to you related to fellowship position. You just want to add some additional fellowship slots, child adolescent fellowship slots?
Yeah, we wanted to actually do a couple of different things relevant to what Dr. Coley brought up before, is that we have a great need in our area, which I assume many people do, not just for child and adolescent psychiatrists, but for evidence-based trained child and adolescent psychologists. So my proposal was really encompassing both of those service lines.
Okay, very good. And Dr. Bryant, you and Brittany, this may be something you guys want to think about over this next week, because I know there are some additional slots that you were looking for that we weren't able to get you earlier in this year. And, still, if it's a priority, would encourage you to give us some numbers, and we'll try to incorporate that. Does that make sense, Dr. Bryant?
Yes, sir. Absolutely. That sounds fantastic. We will do that.
Okay, very good.
Thank you.
So let me stop here and just kind of spend 3 minutes. Any additional high-level thoughts related to the general direction of this item that we're developing, or other thoughts? Dr. Martinez?
Thanks, David. Just really a quick question and comment to Sarah. I totally agree. One thing about the counseling, if folks can consider that one of the needs that we're also seeing, at least that are coming attention to the Hogg Foundation, is grief counseling. The number of children that have actually lost a parent or a loved one is actually rather significant and disproportionately is impacting communities of color. So folks can keep that in mind as they're thinking about their proposals. Thank you, David.
Okay. We go to Andy and then Sonia.
Well, actually, that's a great point, Octavia. I think you'll see in some of the TChat ones, there's a big focus on that. And I think maybe we can think of ways to make that broadly available. But David, as we go through, if folks are keeping track, I mean, should they be keeping track like on their PowerPoint, like of what ones they might want to participate in that they currently aren't, or are we going to have a process for that later? I just want to have folks as they're listening to this and hearing things, how should they be? Could you give us just some guidance on how they should be sort of?
Yeah, I think they ought to be taking notes right now, and they have the document that we've sent out that lists all of these ideas, and if you want to be included in that idea, we're not going to add in a large number of additional proposals, but we can include you into that, and so figuring out, yes, I want to be part of that initiative, and if I am, these are the resources I'm going to need in order to do that. And I'm going to need all of that information by the end of this week.
Yeah, and my sense was most of these have like 2 or 3, one institution currently, but like they could be expanded to others. And I think that's the other thing to keep in mind. If you had one that was 1 or 2 institutions, but you don't see how it could possibly be expanded, you probably need to let us, Dr. Lake, that too, because people may get into your idea, but you're like, wait, I can't do that many. I know for the ones we put in, we scaled them for all 12 HRIs. And there's a couple others that are scaled that way, but most of them are not. So just,
yeah,
that's all.
So some of them are institutional specific, but a lot of them have multiple institutions, and these ideas such as in-person CPAN hours, et cetera, that can easily be encompassed or included, or additional fellows or additional CPW sites. Just let us know and we will include that in our thought process. Sonia?
Yes, good morning all. One just general comment here. As I'm thinking about some of the work that I've done with the legislature, there's been a big focus anytime we call these like exceptional items that are, come before the legislature. They want to make sure that there's not duplication of effort. And, that's something that we know is inherent in the strategic plan. I see a lot of things here that fit in nicely in terms of early intervention and prevention, as well as enhancing our service delivery system. But the other piece that I think is important here is if there's something that connects with another entity, making sure that that's number one, that it's needed, and that there's clear collaboration that's going on there. So I think that anything that we can tie back to the strategic plan and some of the, the goals that are listed there, I think will also be helpful, because I think our legislative leaders are going to, again, want to make sure that we're not duplicating effort.
Okay. Andy, let me go to you real quick and then to go to Joe. You're muted, sir.
I know. It took me a minute to figure out. Sonia, I think that's really important. And I think just to say, so we've participated in some review of these with Luann. I'll assure you, like all of the ones in this category of workforce have all connected with LMHAs, others in the area. All of these fit within well-established needs. And all of these fit within the strategic plan. So all of that coordination has been happening just really quickly behind. And I know Luann and the team were really focused on that, as well as each of the institutions. I will just say on need, these aren't exceptional items. These are ARPA funds. And these are for one-time ARPA funds around a surge in mental health. And let me just tell you all right now, the need exceeds what all of you could do if you tried to triple what you could do and were redundant. So there's no need for anyone to be worried about doing things that aren't going to meet needs. If two initiatives end up happening in the same Texas community, then you will get somewhat closer to meeting the overwhelming needs that are growing now, that are swamping emergency rooms across the state. And I think it's important because I think you all know that and you live in this, but I just want to make sure that the public listening to this understands that we are in the middle of an unprecedented mental health crisis that is still building. Children are going back to school now, with parents getting sick, children getting sick, and educators overwhelmed. So I think Sonia's points around coordination are 100% right, but folks need to keep in mind, this isn't your traditional thing. This is this is an ARPA funding that's for one-time funds to surge to a need that there's no way we could meet, even if we asked for 5 times as much money. So I just want folks to understand, who are listening, that context. I think everybody on the call understands that context because you're living it every day, but I'm not sure all the listeners will. I just wanted to make that point.
Very good. So I want to go to Joe and then Dr. Trivedi, and then we're going to need to move on to the next item. And I'd ask both of you to keep it quick so we can cover all the items today. Dr. Blader?
I just want to make a general point about participating sites, that the way our submissions were fashioned was, I didn't want to be presumptuous in who would want in the consortium's overall uptake of the idea. But everything we proposed was with a view toward involving as many sites as possible. So I don't know if others had the same framework. So I think it would might be helpful that instead of saying, well, I want to do this, and this, if there were some way to as we're thinking about this, maybe get some feedback from the proposers as to whether they really intended it for it to just be local to their campus or the people that they co-applied with, or whether kind of the implicit assumption was that this would be consortium wide.
Okay. Yeah, I don't think we have time today to do that. What I need from everyone is whether they want to be involved in that or not. And then we can work through those discussions and figure out if there's, how do we really bundle these into ideas? Again, I don't want to have 40 different proposals. I need to make sure I consolidate this into 5 ideas. And as much as we can have multiple institutions doing the same thing, I think our chances of success are better.
Okay, so what you're suggesting actually is it's not, do you want to participate in each and everything that we've just discussed at that level of detail? It's rather in participate in the broad categories that you've.
In these general, and we can send out more information to you in the next several days. But today I just need to vet these, get your ideas, make you familiar with it, and let you decide whether in those ideas you want to be part of that or not. Okay.
Okay.
And then we'll figure out how do we bundle it. Okay. Dr. Trivedi?
Just one important point, I think Andy mentioned it a little, but I think we have to remember that for the mental health impact of COVID on kids is universal. And I think the challenge we as a field and society are going to face is huge. So I don't think that the problem is small.
Yep. Okay. Why don't we, thanks, Dr. Trivedi, let's move on to the next slide. Okay. And I apologize, I know I'm pushing, but I only got 2 hours, so I got to move forward quickly. So this next category is the enhancement and expansion of the TChat services. Some institutions have identified additional ISDs that they would like to include, UTMB being one of those. Several institutions noted that they would like to increase the number of sessions a child may receive. We actually have 5 institutions that have said that that is one of their concerns and one of their needs that they'd like to fulfill. That another group of ideas had to allow the provider to see select children identified through TChat that may be more complex and need an in-person visit to allow them to do that. The fourth idea under TChat was, and this came from San Antonio, and Dr. Blader, I want to have you talk about this a little bit. Because it's a little bit novel and maybe one of those opportunities for additional collaboration, has to do with the provision of substance use services through TChat when indicated. Obviously, mental health and substance use needs have gone up dramatically here with COVID. The fourth, again from San Antonio, the identification that bereavement is obviously a significant need right now, bereavement services. And to do that and Octavio, I think this meets some of your ideas related to bilingual bereavement services. And then both Texas Tech and UT Southwestern put in proposals related to implementation of evidence-based prevention programs, the youth aware mental health item. So let me, I think Karen, the first item of increasing the schools is pretty self-explanatory. Is there anything that you want to say related to that item?
Self-explanatory.
All right, very good.
Nothing more.
All right, the next item to increase the number of sessions a child may receive. Again, there's 5 different institutions that have put that in. I'm not going to call you out, but that has been an ongoing discussion in these executive committee meetings, that the frustration that you've done 3, but you're not quite there, and then it almost starts over again, and that the need to expand that. Again, I have I think 5 entities that have identified that. I would ask the rest of the institutions, that may be an idea that you'll say that, yeah, I need to do that too, and this is the cost we need to do, that we need in order to do that. Let me then go down to maybe one of the less intuitive ones, but obviously a significant need. Dr. Blader, you want to talk about why you submitted this substance use service item proposal?
What we've observed locally is, I don't know if it's an actual increase or more people disclosing, but it would be consistent with the preliminary epidemiological data that there really has been an uptick in substance abuse, substance use among people, school age folks, as well as, believe it or not, we're hearing about people who just kind of developed a routine, kind of stuck at home, where job hours, have been curtailed. The kids are home, and a lot of them are just using substances together. So that kind of interact, that kind of pattern is what, is the impetus for what we were suggesting to devise a way to have an impact on substance use through T-Chat as well.
Okay. So you're the only institution that put it in, but I think your framing of this would be something that other institutions may also like to do also. And if that was done, then we would kind of consolidate that and figure out how we'd have consistency across institutions in providing that type of service. Does that make sense, Joe?
Yes.
Yeah. Okay. So again, would challenge our institutions to think through that. And I'm not guaranteeing the legislature would buy off on it, but obviously it's going to be a significant need if anyone reading any of the stories related to increased use of substance uses during this pandemic, and figure out what that would take for us to do something meaningful there. Also, Joe, you want to talk a little bit, again, short and brief, related to the bilingual bereavement support for students?
Yes, we perceived the need to upgrade the type of outreach and support that we could offer people outside of sort of the very disorder specific pure psychiatric context to offering bereavement support groups, case management services, also for people who've experienced the associated economic losses and other impacts of be it loss of a family member. We also had a stress component in there to address the aftershocks of massive loss of income, dislocation, as well as bereavement per se. And at least for our population here, it was important to offer those in Spanish as well as English for those who might gain more from that type of format.
And it looks like, Joe, that's been put in as a placeholder, but you still need this week to figure out the budget request for that. Is that correct?
Okay. Well, actually, I submitted afterwards. We submitted to Lachelle. I guess it didn't get there in time, but we did give more detail on our specific projects.
Okay, we'll add that in. And I, Joe, if you're okay, I would ask that if other institutions are doing the same and want to do the same, maybe if they could contact you and think through that related to what it would take to do this on those two items in a smart way. Is that okay, Joe?
Yes.
Okay, very good. And then Dr. Trivedi, you and Dr. Wakefield put in proposals related to youth aware of mental health. You want to talk briefly related to kind of what that would entail?
Sure. So the Youth Aware of Mental Health is a evidence-based program that has randomized controlled trial evidence. We have somebody, Dr. Wakefield and Dr. Martin have talked about the value of that, but we've been doing this at UT Southwestern for the last 4 years, and we've reached about 20,000 students in area school districts and replicated their findings. It decreases incident rates of depression and suicide, and can be very easily done. And that actually is very timely for us. In my thinking is now that we have the infrastructure in place for CPAN, T-Chat, and CPV. This is prior to that. So this includes all students. The proposal, at least we put together, is designed to train facilitators at each of the HRIs, who will then become trainers during the process of this proposal. And the state will be left with an army of trained facilitators that will be able to go to all school districts across the state. And the proposal at least aims to be able to reach 1 million students. So it actually is a very comprehensive and yet applies to all the students. One of the problems that we've always run into is we have run to crises. So we are like first responders. We look at suicide and we look at depression and we look at kids who have behavior problems. And we as a system don't do much enough for all the kids. This is an experiential program that leaves kids with the tools necessary to be resilient and aware of mental health. So help-seeking behavior, etc., so that the crisis doesn't come as a surprise to the kid or the family. So that is the program.
So let me ask Dr. Wakefield, and Alan, I see your hand, but I'm going to wait a minute before I go to you. Dr. Wakefield, anything you want to add to that? And then I guess my question for both of you, Dr. Trivedi, is that what you've outlined here is a statewide initiative, and that how would other institutions, if they were thinking being part of that, just so I don't get duplication, how does that come together in a smart way? And so Dr. Wakefield.
So before, just one quick point, the approach is that we have a group of master trainers. So we will train people at each of the HRIs who will then be training facilitators in each school district. That is how the plan is, to be able to blanket the state.
And so you would leverage the HRIs then to educate the educational service centers that then make the statewide.
And they will become their own hubs in the future, so that at the end of this 5-year period, it will be self-sufficient, and then the schools will choose which of the support structure sort of resources they get, to whether to use this or other. All schools try to use social emotional learning mental health programs. This allows them to use an evidence-based program with people who are already trained and certified.
Okay. Dr. Wakefield, and then Dr. Podowitz.
Sure, and I apologize. I'm home with a sick kid today, so I'm outside trying to escape that, and there's a bird in the background. So Dr. Trivedi's overall state proposal sounds like it would usurp ours. We had already sent a group of our TChat LPCs to get trained in the train the trainer model, and had identified 6 of our rural schools that were interested in participating. So we had already started that and saw how our LPCs really thought it was a great program and liked the structure of it. And we really wanted to have that continuum of the prevention of services and training kiddos on help-seeking behavior and how important that is to our overall continuum of care. But I do think, I don't want to be to duplicate, and so we would be happy to participate in Dr. Trivedi's statewide program.
Okay, Alan.
Yeah, Madhukar, is this work with, the Hope Squad from the Elizabeth Harris Foundation has a pretty large network where they've done a lot of this with the kids in schools. Is this different than that, or is it similar? So I know you worked with Elizabeth Harris before.
So we can tell, Alan, yes, it is different, but can work in simpatico with the Hope Squad. And I work with the Ellen Harris Foundation. The Hope Squad develops these, the Hope Squad kids are like a club. We can go into all the details, but it can merge, but it is different enough. And actually, Hope Squad doesn't have any evidence base in terms of efficacy, whereas this one does.
Okay. So I would
no one thing will prevent suicide, as you, Alan, know very well. This is one thing, and there may be other things that can be added.
Okay. So I'd ask folks if they have questions after this to talk to Dr. Trivedi, but if they could be one kind of YWAM a proposal that's statewide, I think that enhances the challenge or the chances that it's going to be funded. So why don't we go now to the, well, let me take a quick, anything else anyone wants to add to that? Again, I'm pushing hard, but Joe?
I just want to take a moment, if I can, to highlight one concern that we have. I think you might have bundled it under TChat in person. Basically, there's going to be, well, there already is a massive increase in kids who were basically just homebound. The whole pandemic, the whole shutdown of schools and so forth has been just an incredible incubator for agoraphobia, other high avoidance related anxiety disorders. And I think it's going to be a huge problem. You're going to have a lot of kids are going to persevere, get out there and get back to school, but then you're going to have your real hardcore who are going to dig in their heels, and you're setting yourself up for very, very chronic avoidance. It was basically an incubator for agoraphobia and things like that. So what we were proposing was to develop a behavioral protocol that would be very impactful, of course, medication, but with fairly aggressive titration, more so than an average outpatient care, as well as a CPAN push to help primary care folks understand the nature of this problem. And we know a lot of this presentation and the kids, these folks who don't, become very uncomfortable about leaving the house. There's a big somatization aspect as well. They'll show up at the doctor and say, I have this wrong, that wrong. And so that was, we perceive that as a very high acuity need.
Okay. All right. Thanks, Joe. Karen, you and Danette, and then I really got to move on.
So just to clarify, a budget such as with Dr. Trivedi's suicide prevention proposal here that has all 12, is that budget taking into account all 12 of the HRIs and similarly with the others, or people have to add budget onto that?
That includes all the HRIs and their students, Karen.
Okay. So it's really then just a yes, do you want to participate or not?
Yeah.
In terms of what kind of budget, it's really just for what Dr. Lakey needs by the end of the week. For these ones that say all 12, the budget presumes that all of the HRIs can live with that budget.
Correct.
So Dr. Trivedi, if I may, if you could, the folks that are, I think there may need to be a deeper dive in this, just make sure the budget numbers are where everyone feels comfortable. If you could set that up with the entities that are going to be in charge of that and iron out any of those budget numbers and get me the final numbers by Friday, just to make sure that Karen and everyone else feels very comfortable with the amount of money that's allocated to do this, that'd be helpful.
Happy to do it. That's how we came with the numbers. So sure.
Okay. Karen, you good with that?
I'm good.
Okay. Danette?
Yeah, okay. So in regard to the evidence-based prevention programs in schools, I'm not sure that it was tracking entirely in terms of what's being proposed. I'll take a greater look at that, but I just want to be sure that included in that conversation are the prevention programs that are currently out funded by block grant funds from the federal government. So I know that, Sonia will step into this conversation as well, but just to think through where there, could be the need to collaborate, coordinate even greater, understand where those programs are, and ensure that there's not a duplication of effort there. I think we're fully with Andy. He describes that there's a huge unmet need and that anything that is done here will still leave unmet need. And so I support that. I just want to be sure that we're using our resources in the best way possible. So there's that piece of it, but also Sonia used the analogy of an exceptional item process. I think we're all really well aware this is not a traditional exceptional item kind of process in terms of decisions getting made about how to spend state funds, but instead federal ARPA dollars. I am interested to know if you have any insights as to the process that will be followed, because I think the analogy was being used to think about the fact that there are many other entities out that are clamoring for these ARPA dollars. We're going to be having some of our same, looks at unmet needs through our system as well that we're working through right now. And I'm just curious as to what you know about the process that will be followed in terms of evaluating the various proposals that come forward across other entities, not just within what the TCMHCC would put forward, and how decisions will get made in regard to what the greatest need is, what will get funded, not funded. Do you know what that process will look like?
What I know is what I've shared so far, and that we will put our things together. We've had some conversations with legislators, but besides that, it's not, all the ground rules have not been shared with me at this time, but we're going to be proactive and put these items together and bundle them into digestible ideas so that we are set up to move forward quickly. Andy, I'm going to go to you, and then again, I got to move forward. Andy?
Yeah, no, Danette, those are really well planned. And I think we need to make sure that we're doing that. So anything on here that raises coordination issues, I think we need to deal with them. I know for YAM, because I worked with Madukar on this in North Texas a lot and some of the LMHAs there, it's very synergistic and it's different. And it creates more of a framework where you can bring multiple things together. So I think it's not duplicative. And it's also, to me, really fits well with the mental health first aid piece that y'all are doing with the teachers. This creates more of a student up kind of thing. So it's very synergistic. And I think in a given school, they may choose, hey, we're just going to do, this or not. But I think that's why it's 1 million as opposed to 5.5 million students that's projected, because we expect like 1 in 5 schools to want to do this along with other things they're doing. So I think those are good examples. Well, in terms of what we know about the legislative process, and I think nobody really knows because it's new. This has never happened in our lifetime. But I know that there was a desire from several key leaders for what can this consortium do to step up. So this was a request to the consortium, not a consortium. I mean, not a request per se, but like various legislators wondering what can the consortium do. So this is basically putting that out. This is what the consortium can do. What the Institute's perspective is on this is we need to all do our things. We need the children's hospitals doing more. We need every LMHA to get every freaking grant that's out there, and all the more we need to. And so I think my sense is that the main way we need to coordinate is to make sure that no one is planning that on someone else to do something. So to me, one thing, all these proposals are just focused on what the partner institutions can do. And to the extent they involve LMHAs like the one in West Texas, I know that Sarah has talked to those folks. So I think that those conversations are happening. I don't believe from the initial thing there's any duplication in here. I think it's going to be like, bringing, our set of boats to the flood. The LMHAs are going to need to bring their set of boats. And my sense is the big things that are going to drive decisions is it one time? And so one time is huge, because if any of these look like programs are going to go forever, they're not going to want to do that. Second thing is making sure that we have the children's lane filled as much as possible, because that's a gap. Everybody has a hard time with children. Everybody tries their best, but it's hard. So I think those are the two things coming at this particular set of requests. But I mean, my gosh, we know adults are dying of overdose. There's so many other things going on that we need to also be. So hopefully we can all take an everything approach that can be done while making sure that nobody's making promises that pull other people in where they're assuming they have needs. I don't think any of these do assume other people will bring resources to the table. It's more putting forward what these institutions can offer to others.
Luann?
Yes, I just wanted to suggest that after this meeting is completed, we should likely have a meeting with Danette and with Sonia Gaines so that we can be certain that we are aware of what is happening locally and in state government across health and human services, so that we can really look at the big picture as to what is being proposed for children's mental health specifically. I think that would be extremely helpful for us, because I would hesitate to submit something that looks similar to another proposal that goes in from another part of our state. And so I will make a commitment to the consortium that we will do that.
Yeah, we'll have, thank you for that. We're going to be very transparent. That's why we're doing this in open meeting. But I think, the legislature our due diligence of what we can do and putting it down and then sorting this through. Again, we're doing this very, very quickly, and we have to. So let's move forward now to the next item, strategic adult mental health services. These are proposals that were designed to meet the significant increased demand for mental health services for adults by leveraging our infrastructure. And again, the legislature may say some other entity should do that, but the health-related institutions are the ones that in many ways could be able to do much of this work. And so there are, if we could go to the next slide, please, 4 proposals. One would, we've heard this, and we've actually been working this over the last several months, a significant need to provide some type of CPAN-like model for moms. And there's a variety of names that are out there. There's perinatal access through telemedicine, or a variety of other items. We've had many conversations with Dell Medical School, and we've looked at how we can bring this up. This has been a priority for HHSC in the past, and I really do think that you can leverage that infrastructure that we put in place to now provide support for women in the perinatal period. And so we've had 2 entities that have submitted proposals. I know Dell didn't submit one, but it was because they talked to me beforehand, and I told them that we have we've already put together a pilot that is working, but I think this would be bigger than that pilot. So I think this is one where there's other entities that will want to say, if this is an opportunity, we could do that, and it would really be of value to women in our geographic area. And so UT Southwestern has put in a proposal, Dr. Wakefield and Texas Tech, but I would encourage the rest of you to look at if there's an opportunity and whether you have the capacity and you have people trained and could really stand that up quickly, to think through that and think through if we should add you to that proposal. Second component for adults is, heard this from Sarah Martin, also from Tyler, Texas, in the significant increase of needing to provide a CPAN-like support in rural areas of the state for primary care providers. The next item is to implement a suicide prevention initiative. We have one proposal from Houston, and then Andy has talked about his collaborative care initiative, and there's a component of that related to adults. And so let me work through that very, very quickly. I think on the perinatal mental health component, I think it's highly recognized. And again, I know several institutions have put it in. Other institutions have told me that they would like to be a part of it. I'm not sure we need to have an additional discussion. What I do need is for you to think through, and by Friday to say, yes, I want to be a part of that. The second part, and Dr. Martin, let me bring you in and then bring in Brittany. You want to talk a little bit about the rural primary care component for adults?
Sure, yes. We were thinking about pretty much a very similar thing to what we're doing with CPAN, but just opening it up to primary care providers that see adults as well. So basically on all ages service.
And it fits very well with the perinatal health initiative. I mean, it just kind of goes right together.
Okay. And again, the legislature may not buy off on that, but it'll be something that we put out in front of them for them to decide and figure out how it is integrated into the other things that are taking place. Brittany, anything you want to say about that?
Yes, I mean, I just wanted to say same thing for us. And I wanted to emphasize that this is something that we are consistently asked about in our CPAN services. And I think that we believe that it will enhance the utilization on the children's side, because we feel like sometimes what we're getting is people are calling us, and then if we can't help them with an adult, they just get frustrated. Or if it's a younger person, but they're still too old, then they don't want to call back if they have that experience where they're getting frustrated. So we think once they are calling us regularly for kids, they keep calling us. So anyway, this is a high need in our area, especially with the shortage of psychiatrists in the more rural parts of the region. And we do believe it'll enhance CPAN as a whole, and the structure is already there. I mean, this would be much easy for us to add this, it'd still be work, but it'd be fairly easy for us to add this on.
I agree with the need. I just think in terms of positioning this, we should mention that it's a temporary thing to deal with the increased need for these services, or possibly just say that we're going to focus on things related to COVID, but just in the interest of making sure it's not something that's going to be ongoing and it's really a time limited.
For the perinatal one, we have structured it as a pilot in order for us to make that temporary argument, but I fully understand that as a priority.
I meant more for the adult.
Yep.
The adult.
Okay.
Yeah.
Okay, Jeff. Let me go to you, then to Alan, then Octavia.
Okay, David. This will be real quick. I just want to make sure I'm understanding and not confused in terms of your invitation for the sites to communicate to you that they want to be involved in a perinatal CPAN type initiative, and to reach out? Are you talking about, to let you know, with regard to the funding and the pilot program that you're already setting up, or are you talking about adding in to the ARPA request?
So Jeff, I think we may have two parallel processes, just kind of the nature, because we've already put together a proposal for a perinatal one. I think we're going to let that continue, but I think here, if you, Jeff, could and any other institution that in this 5-year time frame, what it would take for you to do that, send that into us, and we'll incorporate that into this. And so I'll be very clear. There's almost two parallel items there on the perinatal, but it's really important, and I want to give them a couple of options. Okay.
Okay, will do. Thank you, David.
Thank you, Alan. Then Octavio.
During Disrupt 1, we actually had what we called virtual guidance, which was the adult network. And we did the 9 counties for our Disrupt region. And there was a lot of activity with it. It was really good, but as you know, we looked at this and it went on. Disrupt 2 did not provide the support for that initiative. So I think that as we start looking at creating a network for adults, that we have to really be careful that if we're going to do something, we need it to be sustainable. What we did here at UNT JPS is we pulled it back just to our providers within the hospital for that kind of virtual guidance. And so as we move forward, if we want to do this, I think the sustainability of these kinds of projects needs to be in, because once we build the expectation, and then we can't fund it anymore and it goes away, we really
I think it's a really good, really important part, a point for all of these, is that kind of having that sustainability plan. And that'll be part of what we'll be working through over the next month as we have that conversation. I think we'll put it out there right now that we'll do that continued work related to, and the legislature will, related to what happens next, and with their emphasis on one-time funding for the funds they currently have. Octavio?
Yeah, David, in reference to the perinatal care pilot, I think that's really great to start to continue from a public health, approach to continue to go upstream. So love the pilot idea. What also makes me think about, in that context, that cohort, we do see disparities. And so remember that the ARPA funds also are to address what COVID-19 has elevated for all of us, even though we're probably all aware of it, which is the disparities and inequities. So beyond just what the points that are here, but all the proposals, my colleagues here, the HRIs can really also elevate and highlight where disparities and equities can be addressed, in addition to the overarching themes of the proposals, would be really important, because part of the ARPA funds, that is their one of the reasons they are coming down, and have recognized why mental health and substance use needs to be addressed so diligently at this point in time.
Okay. No, thanks for the reminder, Octavio. Very good. Andy?
Just real quick, it's so important, Octavio. And I just want to say that a lot of these, while they're not in the summary, do that. A lot of these are very specific to different subpopulations. I think all of these have an equity component to them. The collaborative care in particular, because it's primary care based, has a huge evidence base for Latino and Black communities, as well as more broadly among uninsured folks who, because it's so hard to get beyond primary care. And I just want to note on the collaborative care one, David, I really think, the focus here, if we're not helping, and I think on all these for adults, if we're not helping parents, if we're not making communities more resilient, teachers, then we're also not doing kids a disservice. And while a lot of this falls technically outside what the consortium can do, what we're doing is putting out a framework of what either the consortium or the chairs acting in collaboration could do. And I think it becomes then a planning thing where the legislature can decide, okay, well, the consortium can do this could be done by a group of HRIs. I mean, we're not trying to dictate anything. We're really trying to provide a framework here for people to choose between.
I think that's a good point. The legislature may decide that on some of these items that they may not be work for the consortium, but they will be work for the health-related institutions of Texas, and fund them directly to do some of these items. And so that will be a decision of the legislature and through the midst of these conversations. So let me move now to Sarah. Let me go to you, and then I'm going to move to the next body of work.
Well, I just wanted to reiterate one of the things that Andy said that I think is so very important to have on record, that it is much, much harder, much more intensive, much more expensive to try to get a kiddo better in an unhealthy home than it is to get a kiddo better who has parents who are being treated as well when needed. It's just that continuum of services and wraparound for the child includes treating parents.
All right, very good. Let's go to the next bundle of work, and this is in alignment with our with one of our priorities of research, and so I bundled these and called them strategic mental health research projects designed to address the impact of COVID on mental health services in Texas. And so they really are strategic. These are very focused on specific populations. And I would also say in this discussion that they're not research just for research's sake. These are very much in how do you improve the healthcare delivery system or measuring the impact of COVID right now and adjusting the system in order to meet that need. So there are 6 of these, and I'm going to walk through them on the next 6 slides. Instead of talking through them all here, I think these deserve almost a separate slide and discussion. Again, not in depth. I don't need to know the power calculations and all those type of things. That the basic concept and how many institutions can be included, and just kind of some of those general thoughts. And so, if we could move first to the Family Resilience Tool and Initiative. I don't think Dr. Leslie Taylor is here, but Dr. Babatov, if you want to talk, or Dr. Suarez, a little bit about this idea to develop and implement a measurable clinical decision-making model for screening, identifying, and treating families experiencing mental health concerns and stress during the pandemic. Looking through the information, it starts off in Houston, but then wants to bring in several other institutions in that process. And so, Dr. Babatov, you want to talk about this a little bit?
So what we're trying to do is prioritize family interventions to increase family resilience. Parents and children are identified in the clinics, the integrated clinics, and most of the parents that report elevated anxiety and depression levels based on the GAD and the PHQ-9s are included into the study, where we do baseline assessments, the mini, the questionnaires regarding quality of life, family functioning, and basically parents reporting poor family functioning, they're basically included into a 10-week intervention where we go through the SFCR, which is the Family Resiliency Intervention for Therapy. And we determine, we do baseline assessments, midpoint and end, and we determine if they need further individual therapy, family therapies, or medication management. We hope to expand to 2 other HRIs if possible, and to expand this initiative.
We have a little bit of time for questions, about 3 minutes here for questions. If you have, would like to discuss this with Dr. Babatov, let me go to Dr. Plitzka first and then Dr. Wakefield.
Yeah, I'd be curious on the nature of the program, like how much time does a family expend in one bolus that you're working with them? How many hours or how many days or weeks? And, what is the buy-in from families? I mean, my experience with these kinds of things has been, you get people signed up and they'll come 1 or 2 times and then they tend to drop out. What's your commitment from the families? How have you, in essence, how do you get people motivated for it? And sort of what ultimately, what percent of people really do the whole thing?
So currently in our integrated clinics where we plan to implement this initiative, we have Dr. Sutuyo and I working there, and we usually have weekly family parent seminars where we teach some of the parents that we're seeing about ADHD and common mental illnesses, and we've developed relationships with them. Hopefully, as we try to implement some of these tools, we're hoping that based on the provider-patient relationship and active follow-up by our social workers, we'll be able to keep them in the studies currently that we are doing right now. So we're hoping to also educate them, and we continue the seminars, and we hope to implement kind of like 1 hour weekly intervention services with these families. And we're hoping at least we can get, up to 40 each year.
But open-ended or like 10 course
10.
seminars? 10?
Yes.
And you get people coming for all 10?
That's the hope.
But
That's
you
the
haven't
hope.
tried it yet. You don't.
Yes,
You don't.
we haven't tried it yet.
Okay, yeah, that's the challenge I'll put to you in terms of who want to look at this sort of thing.
Yes, most
All right,
definitely.
thanks.
Dr. Wakefield?
Yes, thank you, Dr. Babatope. I was wondering, who are the clinicians involved in this? And also, is this an in-person or a telehealth facilitated modality?
So the clinicians currently involved will be Dr. Sotuyo, Dr. Leslie Taylor, and of course, Dr. Suarez, under the supervision of Dr. Suarez. And we, in light of the recent COVID surge, we were hoping inpatient, but it may be modified to partly virtual or partly in-person moving forward.
I'm sorry, who's delivering it? You mentioned a social worker. Is it?
Yes, Dr. Taylor, the psychologist. Yes.
Any other questions? So I would ask that if any of the HRIs are interested in finding out more, that they contact you, Dr. Babatope.
Yes.
Have you identified the additional sites that you're planning to expand to, or is that still something that's needs to be developed?
I think for now, and Dr. Suarez can come in, I think we've been talking with Dr. I'm not sure, UT Southwestern?
Southwestern, we had discussions with them, but of course we need to identify others as well.
Okay.
Of course.
I think that would be helpful, Dr. Babatope and Dr. Suarez, if it's a consortium project to figure out how that really is, not just one institution, but really is multiple institutions. And again, I think on some of these, we're going to present everything in front of the legislature and let them decide. But I think there's additional strength when they know that there are multiple institutions and it has that broader support and appeal for the initiative. So if you can identify those, I think it would be helpful in the future success of it. Does that make sense, Dr. Babatope? Yeah.
Yes, please. Anybody interested as well? All the other HRIs.
Right.
Okay.
And I'm sure this, what Dr. Taylor has in mind is mostly around LCSWs, social workers that can be trained to deliver that for sure. That's the most economical way to do it.
Okay. And Dr. Wakefield, is your hand up from previous, or do you have another comment?
Previous,
okay.
I'm sorry.
All right. Why don't we move on then to the Childhood Trauma Research Network psychotherapy proposal from Dell and from UTMB. Karen, you want to start, and then Jeff, if you want to jump in, I think that'd be helpful.
Sure. So this is a proposal that's twofold, but the main point of this proposal is to train therapists in providing evidence-based treatment for children that have been traumatized. So looking both at trauma-focused cognitive behavior therapy and cognitive processing therapy. And we're proposing is that all sites that are included in the Child Trauma Network be involved if they would like to, where they would have, it's a 3-day televideo seminar that therapists could be trained for. And if there were therapists trained at each site, we would then have this cadre of therapists that could provide these interventions to children, this evidence-based treatment to children who have trauma. And it consists of a project, a controlled trial comparing these two types of treatments. So once they have these trauma therapists trained, then they can participate in the study. So it's an additional add-on to the Child Trauma Network. But at the end of this, you'll have this cadre of trained therapists that can provide trauma-focused treatment. So it'll be sustaining above and beyond the outcome of this project.
So it sounds like,
yeah.
let me go to Jeff. It sounds like there's kind of 3 wins. the way that, from my reading of it, there's kids get services. People are trained so they can do this and expand it. And there's an excellent evaluation of which of these two is actually most effective. And if there are certain groups of kids that a certain type of therapy may be more effective on versus the other, that type of information would be gathered so we can improve the delivery statewide of these type of therapies. Is that
And that's exactly it. And you have the therapist trained to do it.
Yes.
So this goes above and it actually goes beyond TCHAT. It goes beyond the research protocols, and it's something that could be sustained. It's really the sustainability, I think, that's probably the key to this and the outcome, because when you sustain a treatment, you want to know that it's effective, and the therapists doing it know what they're doing.
And also reading through here, it sounds like just like the network includes all 12 institutions. The goal would be that all 12 institutions would be part of this project in one way or another. Is that correct, Karen?
That's correct. We really would hope that everybody would participate in this. So it's an extension of the current work that they're doing and can provide all of this to their site.
And then a follow-up, similar to the question that you raised just a little bit ago related to the budget. Have you had a chance to talk to institutions related to those budget requirements? And how did you come up with a $13.75 million budget number?
Well, that's why. So Jeff is here, and it came from Austin with Jeff. So I think, Jeff, you want to explain that. My understanding is that this budget includes everybody, but maybe Jeff, you could provide a little bit of detail.
Yeah, I'm happy to, and you guys have both given an excellent summary of what is being proposed. And one thing I did want to add is we actually have a very small pilot, thanks to some funding from the Hogg Foundation of this, and with just 2 therapists and 2 sites, and we've completed the training program. I've been very pleased with that, and we'll soon, within just a matter of a few weeks, start a small pilot with a total of 30 kids between Galveston and Austin to participate in this. And in terms of the budget and so forth, so this has been an ongoing topic of discussion at the Childhood Trauma Research Network monthly meetings. And so those in the network are familiar with this project, and that we were doing a small scale pilot at just a subset of the nodes, specifically the 2 I mentioned before, and that we've been seeking funding sources to be able to expand this to the full network. I can't say that we have specifically polled every node to say, are you in, are you out? But the response during our discussions seems to be uniformly positive, and people are very much enthusiastic about it. And yes, indeed, the budget was developed with all 12 nodes participating in this study.
All right, very good. Let me move on to the next item. And again, sorry for my rush, but I have 20 minutes left. And Dr. Trivedi from UT Southwestern, the early psychosis proposal, obviously an issue that we've had many discussions on in the past related to the challenges of early psychosis, and wanting to look at evidence-based coordinated specialty care services in transitionally aged youth that are identifying signs of early psychosis. Anything you'd like to say about this?
Dr. Lakey, this is Luann, and this was actually a mistake on our part. This was not Dr. Trivedi's proposal. I believe that Dr. Taminga is going to speak to this one.
Okay.
It did come from UT Southwest.
Okay. So sorry, Dr. Trivedi, I put your name down. I thought it was, but oh, never mind. So that's on me.
I can only handle my stuff.
What's that?
I can only handle what I can do.
Okay. So let me walk through it. And so a proposal has multiple missions to identify, divert individuals from treatment, diversion and get treatment for early onset psychosis for justice involved adolescent and youth. There's opportunities for trainees of various disciplines to participate in the care. And there's a research component and looking at the outcomes, ultimate goal to develop strategies for this population that can be replicated in communities. I don't know if, I don't think Dr. Treminga is here today. And I think because of that oversight on me, that I didn't tell UT Southwestern to have somebody. But this is an issue that we've talked about before related to significant need. And for UT Southwestern, it's something that they would like to have considered through this process. Andy?
David, I'm somewhat familiar. I talked to Carol about this before she put it together. You want me to just weigh in with a little bit?
That'd be good.
Yeah. So basically they have right now a very established early psychosis program, as others do too. And the idea is to take the early psychosis treatment programs and to ramp them up to have a much more direct outreach of the university-driven ones. This would be in partnership with the early psychosis programs of the local mental health authorities, but basically to create, I think, particularly around psychiatric capacity for transitional age youth, and with a particular interest, because this is a big thing in North Texas, of supporting the probation departments, which don't have very many youth with psychosis, but the few they do have are tremendously difficult and challenging. So it'd be, and this is one where I think, Luann, there would need to be discussions, particularly with Danette, so how this fit into that, as well as fitting in with I think the social work school at UT Austin has the EpiNet that's doing stuff as well. So this would be within the context of those existing initiatives, but building basically more capacity to have programs and research to train more folks in doing early psychosis. And Molly, I know is on. Molly, it would be a coordination with the EpiNet thing, but this would be really beefing up what the individual medical schools in the consortium are doing. It's not really, it would be synergistic with EpiNet, but not part of the formal things you're doing. It's a focus thing. And I think Carol, Molly, Luann, Danette should chat.
Okay. Yeah, we'll have during the next several days set up a conversation and flesh this out. Make sure that we clearly understand how this being put together, but obviously a major need for Texas and a major opportunity. Okay. Why don't we move on then to the next one, risk and resilience research. And let's see, I don't think Dr. Nemiroff is here. Israel, you want to talk about this, or Dr. Trivedi, you are listed here, and so maybe you could also chime in to look at the impact of COVID-19 on youth and their families, to identify the role of psychological factors associated with risk and resiliency, and to leverage our established depression and trauma research network. Again, has multiple of our institutions that would be part of this, building on the capacity that's been built over the last several years. Any comments from the group?
Well, if there's nobody else, I can say a couple of words. I think that it's an attempt to take our research network, and when we are talking about both research network, and add direct predictors of outcomes. So until now, the research network focused on mostly looking how things are right now, who delivers what, how delivered, what's the outcome, and so on. What that effort aims is to add additional specific predictors that now can be collected and say, okay, if we have this additional information, whether it's a psychological information or physiological information, they're a component of all of that, can we predict using these tools who will do better and how we treat those people better? It's a little bit different for the two different outcomes. So for trauma network, it will be more in general, people exposed to trauma that we enroll and looking what's the outcome a year after that. For depression network, it is looking on the kids that are in the depression network and see, okay, they already have depression. Now, what are the psychological and physiological predictors that we can identify that will predict who will do better and or who will do better under what type of treatment, since we are collecting data of naturalistic treatments today. Is there a way to make it more individualized? Is there a way to say, okay, you have these type of people, you need to try to utilize this type of approaches? So I think this is a real step forward of taking what we build as a network and now giving it a much more specific additional tasks of making more individualized treatment prediction and moving into helping to create priorities within different treatment types, different matching individual care. So that's my take on general concept of this network and what we would like to do.
Very good. Then we go to Steve Plitzka and then Jeff and then Karen. And Andy, is your hand raised again or is it from last time? Let me start with Steve.
Okay. One question, is this children already in the network who either experience COVID themselves or have a family member with COVID, or are you going to recruit additional people who, i.e. either the child has had COVID or a family member has had COVID? Are you following the current people, or are you going to be expanding the sample beyond what we're currently recruiting?
So this is not, so let's put it this way. This is not specifically for COVID. COVID is a one part of that. That's supposed to cover all the existing children. So we will recruit and try to edit. So as the network continue recruiting, no network is completed in their work. As actually we have 500 or 700 people, we are planning with 2,500 in each network and so on. So we are still in the process of filling the networks with individual based on our original plan. So these funds will be used to collect additional data on as we recruit the new people, and if they're old people who are already in the treatment. So old people, I mean our existing already recruited subjects, if they're interested, we'll definitely have a chance to recruit them as well. But we're still, remember, we are only maybe at 30% of recruitment goals for the total. So we have a huge goals to reach. And now we're trying to add extra additional level of information that we can get from them to make a better prediction. Did I answer?
We're not increasing our total, and we're adding funds to gather additional data.
Exactly.
Yeah. All right, got it.
So briefly, Jeff, and then Karen, and then I need to transition.
Yeah, thank you, David. I'm actually speaking in behalf of Charlie. So I wasn't involved in developing this one, but he asked me to speak in behalf of him. And as Israel just said, yeah, it's 1,500 use from each of the existing networks who would be recruited or would be engaged in this. And we're incorporating, we already have some COVID related questions in the data we're collecting, and we'll be expanding that somewhat. But I wanted to build upon what Israel said to emphasize the importance of the biological data being collected here, because as Israel said, it's not going to be limited to kids with COVID exposure, but certainly will include kids with COVID exposure. I think, as most of us know, COVID does carry some neuropsychiatric sequelae. And so it's not just the psychosocial impact of being in a community during pandemic, but actual potential COVID exposure. Having these biological indices to evaluate that, I think, is an important extension of what we can otherwise do within the scope of the networks as they currently exist.
Okay. Karen, anything you want to add?
Just a quick thing. Who's got the budget? So the budget here for $3 million, is that all 12 sites? And since there are so many submitters, who's got the budget? You know, who to direct it to if there are questions about it.
I'm sorry, what?
I think yes. Karen, I'm speaking for Charlie, obviously, but send it to Charlie and we
sure.
And the idea is the number of patients is fixed. or not fixed, but at least the proposed, I think, talking to Charlie, and the idea would be the nodes will decide whether or not they want to participate. The funds will be delivered based on whether they participate or not.
Okay.
So let me add to that. Again, that's another decentralized component of, for example, we will collect different measures, psychological, physiological. One of them could be better done in Baylor. I'm just making it up. The other one better to do in UTMB, in your shop, Karen. So the funds that's supposed to, the funds will go to the nodes to collect this particular data, and then to whatever mini hub that will analyze this type of data. So it's not open necessarily goes to Dell or to UT Southwestern, but if somebody is particularly good in genetics and will do some metabolomics work that is very important, and that would be Lubbock, I'm just making it up, then the funds will go to Lubbock, the funds are necessary to manage the metabolomics. So
the 3 million, you don't need any budget issues from the other sites. The 3 million is covering everything that could cover all of the subjects that potentially could participate from the network. So it's done. So it's a yes or no from the sites.
I think, Aaron, you're right. In talking to Charlie, the idea was this: if a node agrees to do it, that doesn't mean any of their own resources will be used to deliver.
Right. That's what I understand. Yes.
Okay. All right. Great.
All right. So that's, yeah, have conversations this week, talk to Charlie, and let's make sure the numbers are right. But for right now, just want to give that overview. Let me move, Dr. Goodman, to you. We got 8 minutes to wrap up. You want to talk about the DayNet and kind of thoughts here?
Yeah, 8 minutes is plenty of time.
Yeah, one more too.
So we have another one.
Oh, I'll take half of it.
Okay.
Beyond the impact of active infection with COVID-19, the after effects of the virus can be serious as well. And these cases with ongoing symptoms are often referred to as long COVID. So in addition to the well-recognized psychosocial impact of severe COVID, individuals who develop COVID may experience both acute and longer-term neuropsychiatric sequelae. This was mentioned just earlier. And that could be as a direct effect of the virus on the brain. Loss of smell and taste are two common manifestations that demonstrate that the virus can enter the brain. And there is more recent evidence that it can actually enter through the vascular system directly. Some of the most common psychiatric symptoms of long COVID include anxiety, depression, PTSD, fatigue, and sleep disturbances. And increasingly, we can expect to see patients presenting with exacerbations or newly diagnosed psychiatric disturbances. Evidence-based best practices for evaluating and treating these patients are sorely needed. The infrastructure of the consortium offers a unique opportunity to coordinate care across the state of Texas and to refine our approaches as we learn from our collective experience. We propose a unique model that involves adapting our evaluation and treatment practices based on the outcome data we gather in real time over the next 5 years. And if I have another minute left, could we ask Chadi Abdallah to join? Because he's the first author on this proposal.
Okay. 1 minute.
Sure. Thank you, Wayne, for the intro. I just want to add that kind of COVID provide a kind of new challenge. You want to do the research to figure out what are these sequelae. You want to do the development to see what's the best treatment, and you want to provide the treatment, and you want to do all of those at the same time. So the idea behind this is mainly to provide this coordinated, standardized, adaptive treatment where we can integrate both collecting high quality data, update our treatment approach, and implement the treatment. So kind of benefit also from the huge literature that we're seeing about this topic, more than 160,000 publication in a year. So the idea of this data net is to integrate all of those at the same time in real time and collect data and provide treatment.
Okay. And it looks like there's 6 other entities that would be part of that? And Wayne, just want to be clear.
We're open to any and all joining.
Okay.
They would send an email to you, Wayne?
Yes.
Send if you want to be part of that, contact Wayne, and then Wayne, if you could get us kind of that finalized what the budget would be, and then we will move forward with that. Okay. Octavio, 30 seconds.
Yeah, no, a quick question to Wayne. I don't make an assumption, but that will include multi-system inflammatory system in children as well, and any sequelae, I would imagine, not just.
Yeah, I think we initially wrote it focused on adults, but it should involve adolescents and children as well. Do you agree, Chadi?
Yes, definitely. Actually, the idea is to start with a working group to identify really where is the need at this time, and then start from there. And definitely these inflammation, more info about how the virus is directly targeting the brain, more about the cognitive impairment that we're seeing and this chronic fatigue symptoms. So this really mainly the idea is to establish this working group, follow the science, what assessment do we need, and then implement the treatment.
Excellent, thank you.
All right, let's go to the final one. Israel, if you could discuss this, you got 2 minutes. Israel.
Oh, thank you. I so appreciate of having the equal time like everybody else. So let me just put it this way. This is a proposal that actually it's the providers of the wrong word there, and it's not singled by Israel Lieberson. It's actually Israel Lieberson, Madhukar Trivedi, Charlie Nemerov, Sarah Wakefield. So we have a group of people here. And the idea is so there is a population that falls in between the chairs and in the gap between the childhood and adulthood. They are all within childhood network concept, which was what we're talking about is 18, 19, 20, 21. We extended a little bit more for 22, but this is a transition group, and we're specifically talking about students. This is a group of kids or adolescents who leave home, lose most of their direct support system, lose their access to healthcare many times because they kind of transition into the university-based healthcare. And that and at the same time, they take on a lot of stress and now additional stress with COVID. And this has been recognized by the concept of there is a nationwide movement to look on the depression on college campuses and so on. We have not specifically targeted this group at all. We would like to target it because that will close the gap between our focus on the children and expansion to the adult. We would like to look on their treatment, evidence-based treatment. We would like to use it's all using the same network because those kids right now or young adults that I'm talking about, they are within our depression network. We recruit them anyway. Right now, what we would like to do is specifically make sure that those who are willing and interested will get evidence-based depression treatment. And again, we're going to use physiological and psychological predictors and say, can we say who will need treatment, who will need more treatment, and what type of treatment, who will respond to psychotherapy better than they will respond to that, and so on. So it's trying to catch this what we consider at-risk group that has little resources, or because they don't know how to reach the resources that are available there, and look on the outcome of the treatment, evidence-based treatment with them, and B, look on the predictors in order to individualize it. I think that's pretty much summarizes the proposal. And I'm sorry, the proposal is open to everybody. Some of the physiological measures will be better collected. For example, I'm just seeing Wayne on my picture. So Wayne will say, my people here are interested specifically in biological predictors, specifically genetic ones. Okay, well, let's talk to Wayne about him looking on the genetics one. Somebody will, but other places would say, you know what, it's difficult for my IRB to approve genetic one. I said, okay, well, doesn't matter. You don't have to do necessarily a genetic one. You can add EEG if you're interested in EEG predictor, because there will be 4 or 5 centers that will be interested in doing EEG. And Medukar might be has most experience in that. So it will be a recruitment. Everybody will have the chance to participate, and everybody will be able to choose what are the physiological, psychological predictors they can collect, and that will be subgroup of those centers. So we'll try to be as inclusive and as flexible as possible. And obviously we can get to the point of, but we calculated based not on the centers, but calculate again based on what needs to be done with the kids. This is how the general budgets are built together. So if we plan to fill that with the kids, whoever will step in from the centers and say, I want to do that and I want to do that, we'll include them, and they will be part of the process in a way similar to what I mentioned about the overall outcome, risk and resilience. This is with specific focus.
Okay, so thanks, Israel. So I guess my request would be that individuals that are interested to contact you and get information, and then at the end of this week, I need to have then that full proposal that would be included and fleshed out, and who's participating and the total budget number. Again, we're out of time now. We're a couple of minutes over, but what I need from folks is to use this PowerPoint, use the information that we provided last night, go through and figure out where your institution may be able to take advantage of some of these ideas. I'll have folks send out some information, and for these research projects, you have the listed, the point person, and if they could flush out the details and make sure that we have the good solid budget numbers for everyone that's going to participate, and get that to us. I know that's a lot in a short time period, but we're kind of under pressure to get this done quickly because of how quickly this process may occur.
David, will you?
Yep.
You said you'll send out contact information for the research projects who we should contact.
We can send that out. I'll have
That would be
Luann,
helpful.
Yeah, Luann, if you could send that out, we'll get that out today to the folks. Okay.
For the non-research projects, the broader projects around CPAN, TChat, is it just assumed everyone's participating and there'll be a master budget, or do we need to indicate we want to be involved in those as well?
Let us know what you want to, looking through what's here, if you said that, such as CPAN, extended services, or in person, I'm not going to assume that you can do that. I need to hear from you.
Okay, all right.
Do that.
But as far as budget, do we propose a budget back to?
Send it to us.
Okay, so, all right.
Yeah, send it back to.
So you're
Luann.
expecting, for each of these projects, we got to decide in or out. If we're in, we send you a budget. That's the process?
Yeah, for right now. And there may be some refinement.
All right.
Putting things together fast. I don't plan to bring a final budget in front of this group and have you vote yay or nay for each other on this. Rather, we'll just refine the numbers and then provide that to the legislature, and then we will work in working with them and working with you to make sure that we then end up where we need to be. Does that make sense, Steve?
I think so, yeah.
Yep. Luann,
one clarification, David.
In order to make this.
I thought that some of the projects had already incorporated all the sites in their budget. So we still have to put in our own budget.
I think for those that put in for everybody, just make sure that the people that have put those in, that it makes sense. For the other items that you're not included, and Michael, for you haven't provided us yet because of your vacation and other things that were going on, that number. Let us know what those are, and we will put those together. Okay, and I'll have folks coming out of this meeting send you some additional guidance. Okay.
I mean, I don't want to complicate things, but let's take an example. Let's say we want to be in the pediatric collaborative care, and right now that's showing a budget of $281,996 that's been proposed. we ignore that number. We just say, well, this is what we need at UT San Antonio if we want to be in that. And then just go down each of these lines in the spreadsheet and do the same thing, right?
Yeah, tell us what you would need in your institution to do that.
All right. So we don't assume that that number that in the spreadsheet, Excel spreadsheet, represent anybody's. And you're gonna come up with a new number, putting it all together.
And unless it said it's including everybody, or that you're listed there as getting funds, then I wouldn't assume that you're getting money related to that idea yet. And send us what it would take if you want to be included. Okay.
Dr. Lakey, we may want to just send out a spreadsheet that lists each of the initiatives we talked about, and people can opt in or out and then give us what their budgets are, and then we can consolidate that.
Yeah.
Because of course, some of these budgets will depend how big, if you're going to be, well, collaborative care, you could do with 3 practices, or you could work with 50 practices. And that it's kind of hard to say. That's where it gets difficult to get to a right number.
And I guess, but my other kind of guidance here was, don't put something down that you're not going to be able to do. You'll be realistic on what you can do. And so make sure, we're going to trust you, that put down what you think is a reasonable amount of work that your institution can do in light of everything else that you're doing right now. Okay. Dr. Trivedi?
So for some projects like the one we proposed, where we are assuming all 12 will participate and we had some sense of our direction of the budget, we would try to homogenize so that no one node is 3 times the cost for the other, or are you saying we would have variable costs?
Let us look at what you send in and see how you justify it. And then we worked with your institutions before to try to provide that feedback and figure out what makes sense. But I'm going to be careful that I'm not too strong with a filter. And just again, I want to make sure, especially if your presidents are saying this is what we can do and this is what it takes. We're going to trust your presidents to say that's what it's going to take to do this right. Okay.
Lachelle, your suggestion to send out a table is very helpful. I think that's going to help all of us.
Yeah, we'll send out information, but in the meantime, I need you to think through using this on what would make sense for your institution to be part of. Okay. Anything else? Well, I'm 8 minutes over, so I apologize, a little grace here, but I really appreciate everyone participating. And I know I pushed through quickly, but this was we could only get 2 hours from all of you related to all your other activities to maintain a quorum. So look forward to additional conversation this week as we try to refine this.
Thank you, David.
Thanks, everyone.
Thank you.
Thank you, guys.